You know, Alex yesterday presented something about the old Egyptian. And he presented the foot of Tutankhamun. Today I'm going to present somebody else. Look to this picture, 1,000 years ago, and compare it. Look to this foot. Look to the muscles of the calf and the other side. He has atrophy of the muscles. So the diagnosis is, most probably it was poliomyelitis. Which deformity? Cavus and equinus, equino-cavovarus deformity. And what was the treatment? This walking aid on the opposite side, like we do now. So this is the history, the real history of foot deformities. He was a doorkeeper. Doorkeeper was a very important position in ancient Egypt, thousand years ago, because they were treated, the handicapped people, normally. They take all the good positions in the society. And these are my papers about ancient Egypt and deformities in ancient Egypt, because somebody asked it to have a look on the papers. The neuromuscular deformities, what's the cause? Muscle imbalance. It's as simple as that, muscle imbalance. Spastic against less spastic. Spastic against paralytic. So it's muscle imbalance, purely muscle imbalance, which led to structural alterations. Structural alterations, you can have bony changes, you can have other changes. What are the types? You have upper motor neuron lesion like cerebral palsy, stroke, lower motor neuron lesion like Charcot-Marie-Tooth disease, poliomyelitis, and muscle disease or lesion myopathy. It's a big world, the neuromuscular deformities of the foot. It's not one thing. Perhaps with each one of them, like a stroke, you have a scheme and you have think about many things before treatment. Anyhow, I will talk about it generally. Prevalence, it's common. It's not something rare or something like this. Almost all patients with a spina bifida will experience problem with the foot deformity. Almost all of them. This is an example. If you look to the cavus foot, it's common. It's between 2 to 7% in all children. 10 to 25% of the population may have cavus foot, and most probably the cause is neurological. The deformities can be equinus, calcaneus, varus, cavovarus, and various toe deformities. And this is an example of the deformities. Now we'll show it to you. We have elevated medial arch, plantar flexion of the first ray, adduction and the pronation of the forefoot, heel varus, heel equinus, closed toes. So you have to take it systematically. The ankle, hind foot, midfoot, forefoot. And you have to analyze it. Because sometimes it's progressive. It started with something and end up with another picture. Evaluation. You have to ask 3 questions. Is the foot plantigrade? Where is the pain? Is the foot supple, flexible or not? It does make difference if you treat a flexible foot or a fixed foot. The symptoms. It depends upon the etiology, but I'll give you one example in Charcot-Marie-Tooth disease. Ankle instability during walking. Frequent falls, just like this. frequent falls. Pain in up to 60% of patients. Evaluation. You have to examine the spine, you have to examine the hip, perhaps you have dysplastic hip, you have to see the knee, and I will show you examples. Like this picture. This patient had spina bifida, a high one. So the underlying disease must be controlled as best as possible, usually in conjunction with a neurologist. You need a neurologist. In many cases, when you have a cavus foot, stiff foot, and we don't have a real diagnosis, we send him to the neurologist. Deformities of the foot and the ankle in neuromuscular condition are often complex and occur at multiple levels. It's not one level like ordinary foot deformities. Full motor and sensory examination. You have to examine the ankle, hind foot, midfoot, forefoot, and the toes. The quality of soft tissue should be assessed. You see, you have to see the callosities and the special tests. You have to evaluate the gait. It's very important. You see this patient. It's quite unstable ankle. Look. With deformed foot. So you have also unstable ankle. If you treat only the deformed foot, you're left up with unstable ankle. And look to the gait, equinus foot, and recurvatum knee. You have to look to the other joint, you have to look to the spine while he's walking. Is it a compensatory deformity or the same or another deformity? You have to do weight-bearing films to see the primary and secondary deformities, because the deformity in the foot is to correct another higher deformity. So if you treat the primary deformity, you have to treat the secondary deformity as well. 3D printing sometimes is important. I have a case with almost 90 degrees rotation from the ankle after arthrodesis in neurologic conditions. So you can have a real shape of the ankle with 3D printing. This is very helpful, sometimes in difficult cases, for diagnosis. And I will give you an example, valgus deformity of the hind foot. If you have a valgus deformity, look at this. How to analyze it? What can cause valgus deformity of the hind foot? Ankle. So the deformity can be purely in the ankle, or subtalar joint, or both of them, ankle and subtalar. Why to analyze it? Because I know that some people think that this patient has valgus deformity, I'm going to do subtalar, so and so. This is not true. You have to analyze it quite well. And this is valgus foot in myelomeningocele or spina bifida. Pes cavus. You see the concavity, the plantar concavity. And you have to take care of the compensatory movements. Most mild to moderate ankle deformities are well tolerated by a mobile foot. This is because of the ample motion available in the hip, knee, ankle, subtalar, and forefoot joints. So take care before you're trying to do surgical correction. Because this patient might have a mild deformity, neurological deformity, and he is well compensated. A free range of motion, and you do something, you decrease the range of motion, and the outcome will be poor. Treatment. Usually it is non-surgical treatment because it's common. You have many ankle and foot deformities, neurological problems or disorders. General rehabilitation strategies. Initial treatment is usually non-operative, especially when the patient in the recovery phase of the neurologic insult. You have a stroke, so you have to wait. You cannot correct it with a stroke. You have to wait. So you have to wait for a year sometimes, because if the rehabilitation program is fine. Non-operative treatment consists of many things: comprehensive rehabilitation program that usually includes physical therapy, splintage, serial casting, bracing, muscle relaxants, nerve blocks. When neurological efforts are not successful in preventing problematic contractures and the patient is beyond the period of neurologic recovery, operative management is considered. What type of surgical treatment? Almost everything: soft tissue release or lengthening, tendon transfer, hindfoot or midfoot osteotomy, arthrodesis. Remember, in neurologic conditions, this is patient-specific surgical intervention. You cannot say, in this case, you have to do this type of treatment. No. Because each case is different, and I will show you examples. Why? The most common causes of failure of surgical treatment is incomplete correction of the deformity, that most of the people prefer over-treatment, mild overcorrection, and muscle balance was not considered. Muscle balance is very important in cases of neurologic deformities. Why? Because this is the real cause of the deformity, which is muscle imbalance. And this is an example of the valgus foot. You have valgus position of the feet and the ankles, usually in combination with planovalgus and pronation of the forefoot. It's not that simple. Look to the foot, it's pronated, it's clear. Again, the valgus can be in the ankle, subtalar, ankle and subtalar, right? Look to this case. There is abnormal shortening of the fibula, which leads to valgus deformity. So shortening of the fibula can lead to valgus deformity in paralytic conditions, like spina bifida or poliomyelitis. What we do fibular lengthening. And this is the example. You see, the fibula is higher than the tibia. That's why the patient goes to valgus while walking. There is no support on the lateral side. We did fibular lengthening. This is fibular osteotomy and lengthening. And you see now. This will prevent the valgus. So if you analyze the valgus deformity and you knew that this is just or part of the problem, that fibular shortening, and you do fibular lengthening, you corrected it. And by the way, I'm not foot and ankle surgeon, that's why. So, you see before and after lengthening of the fibula. Poliomyelitis. In this case, again, the fibula is higher than the tibia. Again, we did fibular lengthening, and this is the end picture with the correction. Valgus foot. Again, you can do calcaneal lengthening, lateral calcaneal lengthening. This is the osteotomy and separation and the graft. And this is the end picture. It in the right way, but this is not true. In the foot, you can have more than one apex of the deformity. The medial column of the foot is always more plantar flexed than the lateral column, but the lateral column tends to be more fixed and rotated, like this patient. This is an apex of the deformity, but there is another apex here. So you have to do wedge osteotomy here to correct the drop of the first metatarsal. Deformity correction, how to correct the deformity or the structural changes, especially in neglected cases. In case of any doubt, overcorrection is better than undercorrection. The real merit of gradual treatment. What's the real merit of gradual treatment? And this is my paper about correction, gradual treatment of foot deformities. Acute, you can do soft tissue release and tendon transfer. Acute, it's okay. Gradual, osteotomy followed by distraction or arthrodesis without wedge resection followed by distraction. What's the difference? When you do arthrodesis, you remove wedges to correct the deformity, but we don't. We just remove the articular surface and we leave it as such. And then we correct 1 millimeter per day. Or you do combined acute and gradual, and sometimes you need it to do both of them. This is the real merit of gradual treatment. You corrected the deformity, we did osteotomy here, and we did triple arthrodesis, and we corrected the deformity. It was a cloto. But look to this picture. Still flexed. Do you know why? You know why? After the operation, we noticed that the big toe is calm. It's cold. So, and the patient, and it was painful. So we flexed it. And so the circulation became okay. This is immediate postoperative. This is just a wire. Then, every 3 days, we corrected in the outpatient clinic till we get the correction again. So it's another sort. Our plan was acute treatment of the cloto, but we changed it into gradual treatment. And this is the real merit of gradual treatment. You control the tibia, you control the hind foot, you control the forefoot and the toes. Sometimes we add another fixation here. So we divide the foot, hind foot, midfoot, and forefoot, and toes, if you want to. I'm not going to talk about the type of fixator because this is not my game. It's just you fix and play, and you do whatever you want. Like this picture, you see, again, cavus, quinus, cloto, and again, this is acute treatment, but not completely acute treatment because after this, because we did triple arthrodesis and the gradual correction of the deformity afterwards. Triple, just we remove the articular surface. Muscle imbalance, you can do tendon transfer, like this patient. Tib posterior transfer, plantar fascia release. Arthrodesis should be performed with muscle balancing procedure. Again, muscle balance is very important. Like this patient, 44 years old with old polio, and he has equinocaval. Of course, we did long film. He has varus on the other side. You have to find the whole limb. The operative plan was acute, combined acute and gradual. Acute, percutaneous tenoplast endoachilles, release of the plantar fascia, or Steindler procedure, and Jones procedure for the big toe. And gradual, triple arthrodesis, external fixation, 7 days waiting period, and then gradual distraction. You see here, this is immediately after. You still have the full deformity and cavus deformity. Then we do gradual distraction. This is the lateral incision, this is the incision for the big toe, and this is the end picture. This is another type of osteotomy where you do it. It's called the smile or U-shaped osteotomy. Charcot. You've listened to 2 lectures about Charcot, but I will talk from another point of view. It's a potentially limb-threatening condition. And diabetes is a major epidemic in the world. And the prevalence is increasing. 10% of the population of them have neuropathy, and they are liable to have Charcot changes. And you see this case, severe deformity, like this case. Neglected, uncontrolled diabetes, type 1, no history of trauma, and this is the picture, totally dislocated ankle and Charcot changes. Our protocol means corticotomy first technique. We do corticotomy at the beginning of the operation. We apply the frame. Then we do transfibular approach from that side. Retrograde K-wire fixation to be sure that in good position in the operating theater, because the frame will cover this area. You are not going to be sure of the position of the ankle after the operation. Like this. Then distraction continues up. Early wood bearing. We use this for early wood bearing. This and the empty part to allow for the wires not to touch the ground while the patient is walking. And then after 2 months, we do retrograde wire removal. We believe that when we remove the wires, this is going to stimulate this, the part of the docking site. And we continue the lengthening. Usually the patients with Charcot, they have severe pentrac infection, And we remove the fixator prematurely, about 4 months. Usually it takes about 6 months to completely unite. We remove it early, and during removal, we put multiple wires again, retrograde, and casting. You see this type of cast? Affected chronic ulcer, history of one-ray amputation in a wheelchair. She had all the requirements for amputation. What we do? What to do with the soft tissue defect? Because the plastic surgeon refused to do anything. I will tell you how to deal with the soft tissue defect. We use the transfibular approach, and we do intentional bone displacement to reduce the defect. This is the tibia, and this is the fibula, and this is the foot, and this is the soft tissue defect, big defect. After debridement, it's now, you see the picture, and after debridement, it's going to be more, or going to be bigger. What we do, we remove part of the fibula, transfibular approach, we remove a bigger part to make it a less space, and we push the foot in the opposite direction to close the wound. We created a deformity in the opposite direction till we get closure of the wound without tension on the skin. You see the size of the defect is less. Then I will show you. This is the picture. This is the defect. Put the frame. This is immediate postoperative. The foot, it's not in the reduced position, it is in the opposite position. And still there is equinus, because this was the position to close the wound, just like this. And we put the wires, we know the wires will bend, there is no problem at all. We put the wires just to be sure that it's in the proper ankle position, as you see here. Then we put our hinges and distraction from behind and continue 1 millimeter per day. After 2 weeks, after closure of the wound, then we continue till we have the plantar foot. This is the piece of fibula which we removed. See, gradual. And again, how to do weight bearing, immediate weight bearing. And then we do, after 4 months also, again, premature removal of the frame, and we put the same type of cast, retrograde wires. This is how she walks with the cast. Full weight bearing. We allow her full weight bearing with the cast. Then we remove, and we have after removal, immediate after removal, we have to encourage the patient to weight bearing. If you are interested, we always organize a deformity conference in July. This year, next month, we have this conference. We have these invited speakers. We have people from everywhere in the world, from China, from Russia, from Malaysia, because we like to hear the opinion of all the people. We exchange ideas. If you are interested, please come. We have different way of thinking, and especially in the high population countries. In conclusion, foot and ankle deformities are common in neuromuscular disorders. The aim of treatment is to preserve a painless plantigrade mobile foot. Initial treatment is usually non-operative. Non-surgical efforts, if non-surgical efforts are not successful in preventing problematic contracture, the patient is beyond the period of neurologic recovery, operative management is considered. Remember, for neurologic problems, patient-specific surgical interventions, you have to design your treatment according to the patient, according to the situation. Our recent approach of limb reconstruction based upon the principle of distraction osteogenesis can be considered as a potential hope for neglected cases where amputation is the only solution. We offer them a new hope. Thank you.